What makes clinical placements or work-integrated learning, work-based learning so complex and tricky is all the variables at play. There's the model of placement that's used, and there's still a fair bit of clinging on to the apprenticeship model in some disciplines, despite evidence that the collaborative model is a lot more effective for sites and for student learning. The approach to student learning varies from the watch and do as I do approach through to the placement educator being the facilitator of student learning. And then, of course, students have a great capacity to self-direct their own learning with great responsibility if they're allowed to and if they're well set up to do so. The use of peer learning. Whether or not we use it, or if we do use it, are students actually well set up to make the most of it? It doesn't come automatically. I think students need a particular set of thinking and skills around peer learning to make the most of it. Then we've got unidisciplinary placements or interprofessional placements. Interprofessional placements are becoming more common, and they're very vexed, of course, because of disciplinary boundaries, issues around interprofessional supervision, fear from some supervisors that the students will lose critical time in their unidisciplinary environment and may not achieve the competencies required for registration and accreditation. The jury's out on that. We simply don't know whether putting students into interprofessional placements jeopardises their unidisciplinary placements. Opinion and anecdote says it doesn't, but we don't have hardcore evidence of any substance yet. Questions about who leads the placement. Is it student-led or is it clinical educator-led? The whole range of variables that fit under placement quality, and I'll talk a bit about those later. Issues around level and frequency and amount and type of supervision that's provided. The agent of supervision. Is it the unidisciplinary supervisor or someone from another discipline? Is it the nominated clinical educator and or other people in the department? So I might be the nominated clinical educator for a batch of 4 or 6 students, but you're going to bet I'm asking for help from my colleagues in my department to provide input and support to the students and also to me. We can use input and supervision from non-health professionals depending on the sites that the students are placed in, teachers, carers, disability workers and so on. Interprofessional supervision, of course, student self-supervision and peer supervision, all are part of the valuable mix of supervision input that students can receive. And then we've got issues of supervision quality, the knowledge, skills and attributes of the clinical supervisors and how those might be developed. The ubiquitous question of time, because of the dual roles that clinical educators have, patient care and student learning, and the whole plethora of other administrative and professional tasks that they have to complete at the same time. Time is always very pressured. And when I did my doctoral research, I did use phenomenological methodology. It was a qualitative study of clinical educators' experiences of being a clinical educator, and one of the constant themes was time. And one of my research participants described her day-to-day working life as feeling that she always was looking at a clock on the wall and the clock always had an angry face.